Today, we will dive into another commonly asked question facing every dentist. When should you prescribe antibiotics? Using the evidence-based clinical practice guidelines on antibiotic use published by Lockhart et al. In the November edition of the Journal of American Dental Association, let's understand the clinical recommendations for the same. Don't forget to save it and share it. So, considering an immunological competent adult seeking treatment in a dental setting with an urgent pulpal or periapical condition and definitive conservative dental treatment DCDT available, first question you need to verify is, does the patient have pain or swelling? If there is pain, find out the pulp if it's vital or necrotic. If vital, then it's symptomatic irreversible pulpitis with or without symptomatic apical periodontitis, and no antibiotics as adjunct to DCDT is needed. Definitive conservative dental treatment. If the pulp is necrotic, pulp necrosis and symptomatic apical periodontitis, again, no antibiotics as adjunct to DCDT. Now, if the patient has pain and swelling, then it's pulp necrosis and localized acute apical abscess. Then find out if the patient has systemic involvement. If no, then no antibiotics as adjunct to DCDT. If yes, then antibiotics should be given as an adjunct to DCDT. Now find out if the patient has allergy to penicillin. If no, oral amoxicillin 500 mg 3 times a day for 3 to 7 days. If it's not feasible, oral penicillin V potassium 500 mg 4 times a day for 3 to 7 days. If first line treatment fails, broaden the antibiotic therapy to complement with oral metronidazole 500 mg 3 times a day for 3 to 7 days, or discontinue the first line treatment and prescribe oral amoxicillin and clavulanate 500-125 mg 3 times a day for 7 days. If the patient has penicillin allergy, then find out if the patient has history of anaphylaxis, angioedema or hives with penicillin, ampicillin or amoxicillin. If no, oral cephalexin 500 mg 4 times per day for 3 to 7 days. If the first line treatment fails, broaden the antibiotic therapy to complement with oral metronidazole 500 mg 3 times a day for 3 to 7 days. If the patient has history of anaphylaxis, angioedema or hives with penicillin, ampicillin or amoxicillin, then start oral azithromycin, loading dose of 500 mg on day 1, followed by 250 mg on additional 4 days, or oral clindamycin 300 mg 4 times a day for 3 to 7 days. If the first line treatment fails, broaden the antibiotic therapy to complement with oral metronidazole 500 mg 3 times a day for 3 to 7 days. Yes, antibiotics play a crucial role in managing bacterial infections across various medical fields, including dentistry. However, their indiscriminate use can lead to antibiotic resistance. So when to prescribe acute dental abscess, especially if it's accompanied by systemic symptoms like fever or swollen lymph nodes, progressive infections such as cellulitis or facial space infections, after certain surgical procedures, in patient at high risk of infection such as those with compromised immune system, certain heart conditions or recent joint replacements. Prior to dental procedures for high-risk patients, some patients like those with specific heart conditions might need antibiotics before a dental treatment to prevent infective endocarditis. When not to prescribe, chronic conditions such as chronic periodontitis, where the primary treatment is thorough cleaning and not antibiotics. Pain or swelling without signs of bacterial infection. Most toothaches are best treated by addressing the cause of pain like decay or trauma rather than by using antibiotics. Post-surgical pain without signs of infection. Always determine the underlying cause of dental symptoms before prescribing antibiotics. Remember, antibiotics are not a one-size-fits-all solution. They are powerful tools that should be used judiciously, always with the patient's overall health in mind. Don't forget to save it Don't forget to share it. Take care.